Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning.
Procedure for today's lesson is a sinus procedure. I'm going to be showing you 4 projections: a PA axial, a parietal acantho, submental vertical, and a lateral. We're going to be doing the patient in a vertical position because of the air fluid levels. Sinuses with mucus, air fluid levels, we demonstrate those with a horizontal beam, so we're going to be using the vertical board. A PA axial, think about what the word means. PA will be entering posterior, going anterior. Axial means we have a caudal tube angle. The patient's skull is actually positioned in the exact same position as any PA, but because of the axial, we're going to have a 15-degree caudal tube angle. The purpose behind that is to throw the petrous portion down below the frontal and the ethmoidal sinuses. The Waters projection, also called the parietal acantho projection, is done exactly the same way as any parietal acantho. Submental vertical is positioned exactly the same way, and a lateral is positioned exactly the same way. The PA is primarily after the frontal and the ethmoidal sinuses. Frontal sinuses being here, ethmoid sinuses being here. The parietal acantho projection is after the Waters. Its primary focus is the Waters. The submental vertical, its primary focus is the sphenoidal and ethmoidal sinuses, and the lateral projection is the best projection for all of the sinuses. We intend to include all sinuses in the series on every projection, but again, each one has its different primary focus, and I'll review that when we position. So we're going to go set our room up. I'll see you in a minute. We're set up at the vertical board. I have an 8x10 in the wall bucky with the ID to the top. I've moved the left marker in a ways because we're going to have about 7x7 collimation. My patient is shielded, and I have my tube set up for the PA axial, also known as a Caldwell. It has a 15-degree caudal tube angle on it. I'm going to have my patient scoot up to the vertical board, and remember, a PA is a PA is a PA. We're going to tuck his chin until the orbital meatal line is perpendicular. And I'm going to look at this line again, and for sinuses I want that CR to exit right through the nasion. 15-degree caudal tube angle. Make sure things line back up. Step behind your patient. Make sure the MSP, the mid-sagittal plane, is to the center of the film. You can look at the light on the back of the skull. You can look at the line on your vertical board. And then I'm going to feel for the skull like we've talked about before to make sure that the skull is in a true PA position, that the MSP is perpendicular. Feeling mastoid tips, reaching the board, making sure they're at the same level height. And this would be a PA axial, also known as the Caldwell. Because of the caudal tube angle, again, the petrous ridge is not going to fill the orbits like on a normal PA, but it's actually going to be projected to the lower 1/3 of the orbits. And as introduced at the beginning of the lesson, the reason for that is you are after the frontal and the ethmoidal sinuses, and you want the petrous portion clearing those structures. And so when we evaluate the film to see if we've done a good job of positioning, that's what we will look at. Is the petrous portion to the lower 1/3 of the orbits? And for the MSP, if there's no rotation, the distance from the outer canthus to the lateral board of the skull will be similar on both sides. Again, PA Caldwell is for your frontal and ethmoidal sinuses. We will include the maxillary as a secondary focus, but its primary purpose is for the frontal and the ethmoids. I'm going to position my patient for the parietal acantho projection, also called the Waters. We will have a perpendicular beam Collimation remains the same. Change your film. And if you'll recall, the patient needs to elevate their chin until the mental meatal point. Can you scoot in a little bit more? That's good. Until the mental meatal point is perpendicular. Just a little more. That's great. And then the central ray will exit down through the acanthion, the base of the nose. And you line things back up. I will now look at the MSP, make sure it's centered and perpendicular. And I can look at the nose coming down this line. And then I'm going to look at his orbits to make sure they're equal. Don't use the nose to evaluate if the patient is rotated or not. A good percentage of people have crooked noses. So look at the outer canthus of the eye and the lateral portion of the skull. Okay. And this would be a Waters projection. Its primary, patient can relax. Primary focus is for the maxillary sinuses. If you have positioned the mental meatal line perpendicular to the film, the petrous portion will be projected just to the very apex of the maxillary sinuses. You will see the frontal and the ethmoids, but they are not the primary focus, they're a secondary focus. And again, the outer canthus of the eye, lateral border of the skull, that distance will be similar. We're going to do our lateral next. It would be the logical move. Infraorbital meatal line should be parallel to this axis. That'll keep the patient from looking too far down or looking up in the air. So the infraorbital meatal line parallel to this axis, that plane. Interpupillary line perpendicular, and the MSP is parallel. I'm looking at the outer canthus, lateral border of the skull, making sure that's equal distance. So I'm going to lower the board a little bit. That's good. And you're going to be centered at the level of the outer canthus of the eye. Frontal sinuses will be here, maxillary sinuses there, sphenoids in a little deeper, ethmoids in a little deeper. And this projection is good for all of the sinuses. It's the best one to demonstrate each of the sinus cavities. You changed your film. This is a right lateral for the purpose of this demonstration, so you could see the patient's skull from the camera angle. If the patient is having pain on the left or pressure on the left, then you would do a left lateral. Okay, and you make sure the tube, I did line that back up. So again, the interpupillary line perpendicular, MSP parallel, infraorbital meatal line parallel, demonstrating all four sinuses. Our patient can turn around, so his back's to the board. And I'm going to get set up for the SMV. Change films, marker placement, like in facial bones, sometimes a good idea to have the patient hold on to an edge for stability. Scoot away from the board, sir, please, and lean your head back. Submental is a submental is a submental, and I'm going to position the infraorbital meatal line so it's parallel with the board. And I'm going to enter about 3/4 inch anterior to the EAM. And then I need to look at his, step in here and look to make sure he's centered and that the MSP is perpendicular. And I'm going to open the collimation a little wider than what you would normally have it, just to demonstrate a point here. Okay. I want you to take a look. Camera will focus in right here at the shadow here. That's our patient's nose. And it's a good indication that the infraorbital meatal line is parallel. Larry, we're just going to kind of tuck your chin for a minute, and then they can see that shadow. See what's happened to that shadow? The nose has disappeared, and you have frontal bone being demonstrated. If the infraorbital meatal line is parallel, the nose shadow sticks out there. Okay? And just like when I taught you facial bones, if the patient is unable to extend their chin all the way, you can angle the tube cephalic so you're perpendicular to the infraorbital meatal line. Patient can relax. And the primary focus of the submental vertical for sinuses is the sphenoid and the ethmoidal sinuses. If you've done a good job, those sinuses are free of the mandible because the mandible will be thrown superiorly and the mandibular condyles will be anterior to the petrosa. And the distance from the mandible to the lateral edges of the skull will be similar if the MSP was perpendicular. On a lateral, the sinuses would be evaluated just like any other lateral. The structures should be aligned vertically and transversely. Again, you've got your condyles, your sella tursicas, your orbital roofs. If they're aligned vertically, your interpupillary line was perpendicular. And if they are transversely centered, one on top of the other rather, if they're aligned that way, the MSP was parallel. And that concludes the sinus series today. Hello class. We're going to focus on zygomas now. The zygoma series may vary from hospital to hospital. The protocol or the particular projections you're going to shoot will vary from institution to institution. But a very basic one that you could use is very, very similar to facial bones. You're going to do a PA and you're going to do a Waters, you're going to do a lateral, and then you're going to have a choice of either the SMV or the axial. So you can see the similarity with the facial bones. So we'll just go right into our lesson today. 8 by 10 cassette lengthwise, marker moved in a ways. My patient will face the board, and I'm going to set up for the PA. I won't do a lot of review today because we've covered many of these concepts on previous lessons, so I'm just going to basically talk as I position him. A PA has the orbital meatal line perpendicular. I'm going to exit to the tip of the nose. Collimate to about a 7 by 7. Check to make sure the MSP is centered, mid-sagittal plane is centered, and that it's perpendicular. That would be your PA. It's actually for facial bones, but the facial bone we're focusing on is the zygoma. Patient can relax after you make your exposure. Change your film and the Waters. Patient will elevate their chin. Tell the mental meatal line. A little more, sir. Tell the mental meatal line is perpendicular. Exiting to the acanthyon. Collimation. Check for MSP that he's centered and that the MSP is perpendicular. And that's your Waters. Okay. Your lateral again would be whichever lateral was the injury side. Today we'll do a right. So I must change the marker. And infraorbital meatal line parallel. Interpupillary line perpendicular. And MSP parallel. Central ray is going to be at the level of the zygoma. Okay, and that would be your lateral for a zygoma. And then we're going to turn the patient around. change film, your department may elect to just do the SMV. The SMV would be positioned exactly the same as it was for sinuses or facial bones. So I'm not going to demonstrate a normal SMV to you right now. I'm going to focus on an AP axial, which is an option. I'm going to position for one zygoma at a time. You'd end up needing to do this on both sides so they could compare the two sides. An SMV, when you drop the head back, you're going to see both sides. The patient would be positioned exactly the same way. Some technologists will choose to decrease the SID in order to magnify and throw the zygoma away from the skull. So you may choose an SMV, or I'm going to demonstrate something a little bit different, which is called an AP axial. We're going to have the patient hold the table, lean their head back, just like you did for the SMV, infraorbital meatal line parallel. That will take the zygoma and get it parallel to the film. I think you can see the advantage of that. And now if I'm going to only go after one, I'm going to offset him a little bit, and I'll do this side first. And I'm going to take the MSP. Can the camera see? Well, my hand here. I'm going to take the MSP and I'm going to rotate that 15 degrees away from the affected side. This will be the affected side for the purpose of this demonstration. So we're going to turn his MSP 15 degrees away. 15 is not a lot. Okay, so I double check to see what that is, making sure I didn't go too far with the MSP. And then the vertex of the skull will be shifted 15 degrees away from the affected side. So we're going to tweak his head that way and readjust that MSP. I took the vertex, sent it that way 15 degrees, and his MSP is turned. I'm going to come right down through the zygoma. Here's the zygoma. You can see the centering coming right down through the center there. And I'm going to try to get rid of hair shadow here. We're going to focus on the board. And the zygoma, the process will be projected right here. Let's see. There we go. You're going to see a little shadow come out. If he didn't have hair, you would see just a little curve here. Again, the infraorbital meatal line is parallel to the board. The vertex of the skull 15 degrees away, MSP turned slightly away, and that's going to open up this projection here, right here. Okay? And then you're going to center through that side. Now here we would have a right marker on. I can tighten up the collimation because we're only after one side. And we would shoot that, and then we'd let him relax, and we would do the other side so the doctor had a comparison. Okay? And that would be a zygoma procedure. PA facial bones, waters, lateral, and either an SMV or both AP axials. We're going to show you a couple of projections today for the TMJ, a procedure on the TMJs. More than likely, if a patient needs a series for TMJs, they will be going directly to CAT scanning. The ARRT curriculum still requests that we teach that, so we're going to have a demonstration of a couple of projections today that you might see as a TMJ procedure. One of the positions you've actually seen before is called an AP axial. What's the, think about it, what's the person's name for an AP axial? Comes from the skull series, and it's called a town. Okay, we'll look at our patient now. For the town, the skull is in an AP position, AP axial, and all APs have the infraorbital meatal line perpendicular, and our patient can't tuck his chin to get that point, so I used a sponge to help get the orbital meatal line perpendicular. My tube is angled 30 degrees, caudal, just like it was for an AP axial of the skull. And I've adjusted the gauge to maintain the 40 inches of SID. And the TMJ is right here, just in front of the EAM. So I'm going to want to exit through that point. And we're going to exit to the center of the film. I've placed it 8 by 10 crosswise in the Bucky tray. And I'm using a left marker on the patient's left side. I'm going to collimate this way. This way I need to have the 10 inches. Okay? But this way I can collimate tight for the TMJ. And then I need to check the MSP, making sure it's centered and perpendicular. And this is the AP axial with the zygoma, the point of interest. Okay? Now I'm going to do a lateral. And there's many ways you can do the lateral. I'm going to just demonstrate one of them today. The purpose of the lateral is to, whatever projection you do, is to separate the two MJs. In the lateral position, they're one right on top of another. And you have to do something to separate them. The Albert Schoenberg is the position that I'm going to use today. The skull is in a true lateral position. So we're going to have the MSP parallel and we're going to have the interpupillary line perpendicular. But I'm going to have a caudal tube angle on there in order to throw the TMJ that's closest to the film. I'm going to throw it down lower. And modified laws might be used for this as well. It's a relaxed lateral where the MSP is not truly parallel. The skull is relaxed a little bit towards the table, so one of the TMJs comes forward and one goes back, and then you still need a tube angle in order to throw one up or one down. So let's go to our patient now. We're going to turn him onto his stomach. I'm going to have 25 to 30 degree caudal tube angle, and I already have a 30 degree, so I might as well leave that. And I'm going to have the patient face this way for the camera, this arm to your side. Bend this knee up a little bit. That's good. And I'm going to work on the patient's skull now. Get it into a lateral position. Can you elevate your neck? I think you can see his face, his chin is turned quite a ways down to the table, so I'm going to raise his shoulders up, give him some support there so I don't have to tweak on that neck so much. Can you rest your head down? That's good. Okay, look up at me. There we go. Tuck your chin a little bit. The chin is tucked to get the infraorbital meatal line parallel, again, so the patient isn't looking down or looking up. Interpupillary line is perpendicular. And the MSP is parallel. Now, the TMJs are just in front of the ear. And the TMJ of focus today is his left here. Now, I have to do both. You know, the lesson's not going to show you both because he would be facing away from the camera. So I'm only going to demonstrate the left side. But I know where the TMJ is because I'm using this as a reference point, and I can tell it's right there on the table. Okay? It's right there. And I want the central ray to exit right through that TMJ. It enters superior to the one above it, and it exits to the one of interest right down there. And then, of course, it would exit to the center of the film. The Bucky tray did not move far enough up, so I had to realign everything. And then I have it exiting to the center of the film. And we'll take the tube back, make sure it's transversely centered. Very tight collimation on the lateral, both vertically and side to side. And I can elect to change the plane of the film because it is so tight I can actually go lengthwise if I wanted to. And I'm going to put a left in a ways and then another marker that you would want to use because you're actually going to do 2 of the left and 2 of the right. We want to have the patient have their mouth closed for one of them, and the other one I would want him to open his mouth as far as he can. And so you do an open mouth and a closed mouth of both sides. And so I would mark this with maybe an O for opened or a C for closed as well. Okay? For the lateral, again, you position the skull for an Albert-Schoenberg in a true lateral position. MSP is parallel and the interpupillary line is perpendicular. Infraorbital medial line is also parallel, and you do 2 of each side, one open mouth, one closed mouth. And that would be a TMJ. I'm going to do a demonstration today for a PA axial of the skull, also referred to as a Haas. In the event you need to do a skull series or a mandible series, someplace where you normally do an AP axial, and the patient is kyphotic and they cannot tuck the chin in order to get the orbital meatal line perpendicular, for some extreme reason that they cannot tuck the chin, you can do a PA axial. If you look at the patient, let's just pretend they're kyphotic. They would not be able to lay on their back and tuck that chin, but whether they're kyphotic or not, they can lie on their tummy. So this is an alternate way to do a town. It would be referred to as a PA axial, and the gentleman that developed this position, his name was Haas. So refer to it as Haas or PA axial. Be prepared for either on a test. We're going to position the skull in a PA position. Recall that the orbital meatal line will be perpendicular. Patient needs to tuck his chin a little more. That's good. And now with an axial, I must have a tube angle. For an AP axial, the tube angle was caudal. For a PA, the patient's reversed. We've talked about this before. Whenever you reverse the patient, you reverse the angle direction of the tube. So I'm going to have a cephalic tube angle, and I'm going to have 25 degrees cephalic. And where I want it, I've got it exiting to the center of the film here. And then I'm going to float my patient to where I need them to be. 25-degree cephalic tube angle. I've adjusted the gauge to maintain my 40. And now I'm going to float the tabletop, float my patient to where the inion, feel on the back of your skull, the bump on the back of your skull, it's referred to as the inion, I-N-I-O-N. It's actually the external occipital protuberance. You want the central ray to enter approximately 1.5 inches inferior to the inion, and it will be exiting right here approximately 1.5 inches above the nasion. So I'm happy with the centering on this patient, and the last thing I need to do is check the MSP for centering and to make sure that he is truly in a PA position. This projection, referred to as a PA axial, demonstrates the occipital bone. It's not the preference way to do it because the occipital bone is actually further away from the film, but due to patient habitus and a kyphotic back, you're forced to do something out of the normal routine, and so we have an alternate, the PA axial. I'm going to demonstrate a reverse parietal acanthial projection today, also called a reverse Waters, as an alternate to the normal positioning. When you have your trauma series in the fall, you'll actually be held more accountable for this, but we like to let you see a preview of it because your patients are coming in a trauma situation. The setup with this would be the patient is traumatized and they cannot be in a vertical position. It's for facial bones or a zygoma or for some other traumatic reason to one of the facial bones. So you do a Waters for many of those type of exams, and you're unable to have the patient turn onto their stomach to go into a PA position. Now the normal parietal acanthion would definitely be the way, the first choice, because you're going to get the facial bones closer to the film. You're going to do a better job of demonstrating the facial bones. But in the event of trauma, I still remember one time when I did a trauma series, and we did not realize the extent of his injuries. He was a construction worker, and a 2x4 had blown off of a roof and came down and hit him, high gust of wind, and hit him in the orbital region, and it didn't appear to be too bad. And so we turned him over and we were doing PA work, and when we turned him back onto his backside, the blood flow and gravity actually forced the eyeball further out of its socket than normal, and I still vision that, you know, when I think of trauma. So in serious trauma situations, you do not turn the patient into PA modes, even though technically it's a better way to do it. But the instructor who teaches trauma next fall will focus on this more, but we're teaching skull work today, so I just want to give you a preview or a glimpse at what a reverse waters would be. Patient is in an AP position. A parietal acanthio, it is the mental meatal line, needs to be perpendicular. So I'm going to have the patient extend the chin as far as he can go. May need a little help. I may have to put a little sponge underneath his shoulders. Here's the mental meatal line, perpendicular. You're going to exit at the same level, right down at the base of the nose, at the acanthion, exiting to the center of the film. And then you check for the MSP for centering purposes, and that there's no rotation. I'm looking at the outer canthus, lateral border of the skull, and that would be a reverse waters or a reverse parietal acanthion. In a real trauma situation, it may not be likely that you're going to use a sponge and to have the patient extend that chin more. So we're just going to kind of mock it here a little bit. He can extend his chin, but take a look that the mental meatal line is not truly perpendicular. Okay, I think you can see that. If it was perpendicular, it would be parallel to the central ray. Well, if I can't get the patient to be perpendicular, I'm going to adjust the tube, and I'm going to put a caudal tube angle on there to match that mental meatal line. Can the camera see the two things here I'm trying to do? And I can just use, to make sure that I've angled correctly, I'm just looking at the black line matching the mental meatal line. Here's the mental meatal line, and see how I now have that black line parallel. Then I would adjust my SID for the amount of tube angle that I have, which is 10 degrees in this scenario. Come down to 38 on the gauge to maintain the 40. And again, I'd exit at the same level, or enter at the same level, entering at the acanthion, exiting to the center of the film. And then I go check the MSP for centering and to make sure there's no evidence of rotation. And that would be a reverse waters that you could use in the case of trauma. Thank you for your attention, and bye-bye.